share with us his thoughts on future of brachytherapy. As probably many of you know, he's very active in this area, assistant professor at Mayo Clinic, but also a member of many task groups and working groups within the APM focused on brachytherapy. And I believe he is vice chair of the working group on brachytherapy clinical applications. So look forward to your talk.
Well, thanks. Can you hear me okay?
Yes. Yeah.
Excellent. I see those polished presentations from the vendors, and it's always so surprising. What you're about to see is going to be rougher, right? This is the R&D. It's going to be my summary of kind of taking a survey at some of the literature out there and trying to share a vision of what I think brachytherapy might look like in 5 to 10 years from now. And so all of these kind of rough ideas and research that's ongoing. And I mean, you saw earlier work that was presented, and this makes it into a very polished format down the road. And so you get to see the early stages a bit here. I'm Dr. Christopher Deufel. I'm from the Mayo Clinic, and I do want to thank the organizers for a chance to speak today about the future of brachytherapy, treatment planning, and quality assurance. And I titled this Automation, Modulation, and Robots. What is the future for brachytherapy treatment? And I don't have any conflicts of interest to declare. My goals for this session, I got 5 of them, so it's a little optimistic. But the first is that you'll be able to describe the potential benefits of automation. The second is that you can list procedure steps that are being automated in LDR and HDR brachytherapy. The third, that you'll understand the impact of automation on treatment planning, specifically brachy planning. 4, to discuss recent automation advancements in automating quality assurance. And finally, explain why the integration of automation with human users is critical for successful implementation. So when you do a SAMS talk, you have to have objectives. So these are my 5. So if you walk away and you've got like one of these, I will consider that a win, but maybe you'll get all 5. So there are 6 people that I do want to acknowledge, because these are people with whom I've chatted. Some of them shared slides. And so it's Dr. Luc Bellieu from Laval and Shireen Enger at McGill, Doug Mosley at Mayo Clinic, Tim Showalter at UVA, Peter Rossi in Colorado, and Shun Jia, of course, and UT Southwestern. And then I also, since there are some heavyweights in the audience here, I should admit that automation is being rapidly implemented. And for reasons of time and space, it's really not possible to feature the accomplishments of all authors out there. And thanks for understanding that any omissions are very much unintentional. So let's start with a definition of automation. And automation is the technology by which a process or a procedure is performed with minimal human assistance. And I like this definition because of the emphasis on minimal, not like no human. And so humans won't be eliminated, but their role is going to change. And it might even become more important. I'll try to make that point at the end, as procedure steps are performed by machines. So I was curious, and I did a PubMed search. I typed in radiation and automation. And what I found is it seemed really interesting around 1995. I also put Moore's law here because I'm going to try to make a comparison with what's going on with computers. So around 1995, we started to see this kind of takeoff of automation in radiotherapy. And I think we're seeing something, I put it on a log scale that looks a little bit like Moore's law. And so why the sudden burst in automation? I just want to provide a little motivation before we dive into it is, why are we seeing this? Is there an explanation for why we're seeing so much automation? And so I'm going to give you a proposal that the emphasis on automation today is due to an available combination of ideas and technology. And so this is a historical example. In 1799, Sir George Cayley understood the basic principles for successful human flight. And however, it wasn't until 1903. And that's when the Wright brothers achieved the first powered flight. So while Sir Cayley knew the power to weight ratio needed to achieve the wind speed to kind of get that plane up in the air, he didn't have the technology, namely an efficient engine. And so he needed a power to weight ratio. And the idea was preeminent, but the technology was unavailable, which leads us to today. So computing speed and data storage, I think, are the reasons that we're changing how we work in radiotherapy. The technology is now becoming available to automate tasks that are currently performed by humans. And I'll try to convince you that this makes it a very exciting time to be working in radiotherapy. I don't draw well, so forgive my cartoon here. But this is like so I've got this cartoon drawing of some blue sky. You got a patient who's going to go through imaging and planning and QA and treatment. A little conveyor belt carries them along the way, and each of these steps happens sequentially and quickly. And so we're trying to improve quality, efficiency, and consistency. So these are kind of, this talk's going to summarize the benefits that we get from automation. And I wrote down shorter procedures. I think we'll see less risk to our patients. We'll see reduced staff fatigue. That's a big win for everybody on this phone call. There's less FTE that might be needed. And I view that as incremental, that I looked at the incidence of cancer and what's expected as the baby boomers bubble through. And in the next 20 years, we may have a doubling of cancer incidence in the United States. And I don't know if your clinic's as busy as mine, but how are we going to handle this? And it sure would help if we had ways to be more efficient. And the last one there is adoption of brachytherapy. Not all centers do brachytherapy, and I have a hunch that some of it has to do with resources. And so if we can make it easier to do brachytherapy, I'm hopeful that it'll become more greatly adopted. I've broken the talk up into 3 categories. The first is automation for applicator placement. That's a small section, and you're going to hear a little bit about robots. The second one is treatment planning, and that's the biggest section. And the third one is quality assurance. And I suppose the reason why one section is bigger than the other is the literature seems to be richer in treatment planning. And I suspect that's because it's simply a little bit more in the wheelhouse, or a little bit easier to target that aspect of our workflow than the other ones. All right, so let's start with the first chapter, applicator placement automation. And this is kind of the first step. Where do you put the applicator? And this is an excellent publication from Shun Jia's team at UT Southwestern on automated guidance on needle placement. And it demonstrates that for HDR brachytherapy, they were able to determine where to put needles in. And so their algorithm not only selected needle locations and dwell times, but it did it in less than 90 seconds. And they did a retrospective on 10 patients, and they showed that it had better organ at risk doses for the same target coverage compared with the manual placement. And I cut out this figure from their paper here, and it shows how the automated needles did a little bit better job around the urethra. And so by targeting the location of the needles around the urethra structure, and a little bit in the rectum too, they got better urethral and rectal coverage by selecting just a slightly different position of those needles. And if you've been in the OR, you've probably experienced kind of that question of, like, I'm looking at one slice, how close should I put this needle to the urethra? How far away? Where am I going to really be using dwells, and what will the distance be away from the structure there? So it's nice to have a program that can take a more global view and optimize it. And that's what this program tries to do. Now, it's one thing to know where you want the needles to go, and it's quite another to place them accurately. And so here are 2 publications on the latest advancements in robotic needle placement, and they have some similarities. They both use percussive systems, they're robotically controlled, and they're monitored in real time. And that last bit seems to be pretty important. That I don't want a robot that's just going to go off and do its own thing, but I want some sort of feedback, or haptic feedback, or some way that the human can assess whether or not they're encountering resistance or bone, or what does it feel like? Because that's what I think surgeons or radiation oncologists, they do know based on feel what to expect. The robots were very accurate. These were phantom studies, and they were a millimeter. That was their accuracy, and they had optical tracking systems, so that they could align the reference frame of a CT or an MRI system to the reference frame of the robot. And that's how they went from the image and then got the needles to be in the right spot. There are also some robot prototypes. Here are 2 publications. And these use special needles that can be deflected to steer into the desired region. And that is helpful because you can avoid having to remove needles and repuncture the skin. So they can bend through the tissue as opposed to the current way, which is pull out the needle and try again. And it never looks that great. I always figure well, the one thing you don't want to show an HDR prostate patient or LDR is what it looks like right after they pull the template out, because they're never coming in that room if you do that. Now you clean it all up and it heals up great, but there are a lot of skin punctures, and I think this is an attempt to reduce some of that. And if you're an LDR enthusiast, this was a cool paper, and it's really impressive. So they have a fully robotic system, and they used it for seed placement, and they cadaverically tested this. So it had some of those same features that I mentioned before. It had optical tracking to align the imaging and the robotic reference frame. It had a human monitoring system for the needle placement. It used force sensing to detect collisions of the needles. And they did end-to-end accuracy. So they put about 50 seeds in here, and they had 2.5 millimeters, which for LDR, I think is fantastic. So the goal here was to prove that you can have some sort of system like this, and a little bit easier in a cadaver, but I think it's very promising. Okay, so that was very quick on robots. But the next section's long. This is treatment planning automation. And I thought I'd give you what I think are the 4 essential aspects of treatment planning, and then I'll organize the automation developments in those areas. So the first is geometry. That's all the digitization, all the contouring. Where is the stuff going to be inside and relative to each other? The second is dose calculations. The third is optimization. And then the fourth is decision-making. So these 4 essential elements, and you're going to hear these throughout the talk. All right. Now, before I dive into that, let's just kind of remind ourselves what the state of HDR treatment planning looks like. And so this is how I sometimes feel when I'm covering brachy cases. So the job is hard. The tools are unsophisticated, and it feels like we're just one wrong step away from harm. And I think a mentor said that to me. He said, brachy's great, you're cruising along, but it goes sideways in a hurry. And I think we all sort of feel that way, and it'd be nice to have some support. So our geometry, this is all the digitization, the contouring. It's largely manual and time consuming and unsophisticated. So all those flashy vendor presentations that we just saw, regardless of those, for the most part, the digitization, the contouring, we're still using these basic tools. And so I decided I wanted to figure out, what does it take to contour an applicator? And we do it, but I documented it. And so it took me 2 clicks to kind of tell the system I want a new applicator. It took me 5 manual entries to set the properties. I had to reorient the applicator 4 times to kind of get it aligned with the image set. I zoomed in and out 3 times. I used 4 clicks to drag a profile that I'm showing here so that I could identify the inner lumen with respect to the applicator. And then it took me 12 clicks to mark that inner lumen. And so it's not uncommon that the geometry process requires an hour or more to digitize needles, the reference items, the contours, the OARs and targets, and have it all reviewed. So doing and checking, that process can take 40 minutes to an hour. The vast majority of brachy calculations, they use dosimetry that overlooks heterogeneities as well as biological and microscopic effects. So very plainly speaking, as far as dose calculations are concerned, we're treating our patients like they are this big bucket of water. I guess to be precise, a 30 by 30 by 30 cube of water. The optimization and decision-making is manual and iterative. And from the planner's perspective, I don't know if anyone's felt this way, but I often feel that the physician doesn't appreciate all the options or the trade-offs before selecting a plan, that there's sometimes time pressure to select a plan as long as it meets basic criteria. And while the planner maybe has some intuition through the optimization iterations, there's not a great way to communicate this to the physician, or at least plant it in their brain. And so we'll talk about this later in the talk. All right, so the current state of brachytherapy treatment planning is filled with challenges, but the future looks better, right? I mean, it's all flying cars and robots. And so here, let's start with geometry. This is future geometry, and I think we're going to see two big advancements. The first will be directionally modulated sources or applicators, and they're going to open up a whole new way of viewing implant geometry. And the second is the automation of the digitization and contouring tasks. Okay, first, directionally modulated sources. So this is the first time you've ever heard of this. I think you're going to find this to be really exciting. And if not, hopefully I'm capturing what you've read in the literature, because I do think it's a really attractive topic. So the image here shows the radiation distribution from an iridium-192 source, so one source. And notice that it is circular and then it's symmetric from all angles from the source. Well, obviously not all targets are circles. And so that circular symmetry limits your dose coverage. And in this example, the dose could not be escalated to a more distant region from the applicator. This is a tandem because of the proximity of the bladder in the anterior region. So you got the bladder up here, and that's the high bladder dose. And so we got this cold region in the corner. And with today's technology, we'd have to add interstitial needles, like one right down here, to break the symmetry and escalate the dose to that cold region. A potential solution is to use directionally shielded applicators or sources. And the figure that I've chosen to highlight here is from Dr. Shireen Enger's lab at McGill, where they've been developing a very sophisticated rotating shield system that can change the angle of a shield. So it's like you got like a window that's open, and you can see down here in this purple. So you've got a shield on the backside, and here's your source. So it's like shining a spotlight. And you can change the angle of the shields in order to shine that dose only over specific angles. And so it's a rotating shield design. And this figure then provides a comparison of the standard dose distribution on the left with that of the directionally modulated source. And so for this one on the right, you've got higher dose anterior, lower dose posterior, and it's consistent with down here where the shields, the pink shield is posterior. And that directionally modulated source can enable all sorts of treatment plans that are unachievable today. So this is a plan where the dose is carved around the urethra by shining that, let me go one forward, by shining that spotlight around the urethra and kind of avoiding going directly through it, they can create a cold spot. But maybe that's not desirable. Maybe we do want 100% of the prescription dose. We don't really know because we've never been able to do this. And I think there are all sorts of neat treatment plans that we'll be able to come up with once we can start to visualize this. All right, that leads me to the other major change that's coming to the geometry of treatment planning. So the first is we're going to probably see new degrees of freedom. The second is just a way that we can handle the existing workload. And so I earlier explained that digitization of applicators is very manual and time consuming using existing tools, at least tools you can buy today. There are clinics that are developing prototype systems, and we're trying to get around the fact that every applicator requires about 2 minutes to create. So what can we do better? For example, can we write an algorithm that finds the bright objects in a CT image? So such as this tandem here shown on the left, where the image on the right is hinting at how this could be accomplished using a thresholding tool. And at Mayo Clinic, we developed a simple tool for automating the digitization for our cervix cancer patients. And it uses that simple thresholding approach and a few other tricks that you can read about in this paper. We got a little GUI here. I got to learn how to write a Python GUI. And it basically, briefly speaking, the algorithm is going to threshold voxels that have high density. So all these black voxels are things that were over about 1,000 HU, maybe 1,200. I can't remember what I chose. And then the second thing is that I have to cluster them. So I used kind of an off-the-shelf clustering algorithm to cluster voxels into individual applicators, plus going to throw away any seeds or artifacts, things that aren't connected to an applicator. And then the third is that once I've got these clusters, I can find the interlumens and then create a plan that has reference points and dwells. and I can automatically select properties because I know this is a tandem and ovoid. I know how long it's supposed to be and its length. And I know what the standard dosing is. There was that GUI, you might have seen that you could select the dose, you can select the ovoid diameters, so you place those surface lines correct. And then it pops right into your treatment plan. And so we've been using that tool clinically for a couple of years. And you know, I'd argue that it's safer because the applicator properties and the names and orientation aren't susceptible to typos or forgetfulness. I'd also say that the digitization is consistent among all planners. So we found that we had about less than a millimeter difference than a human expert. And it's about 10 to 15 minutes faster than our manual process is what we found. Now, this only works if you've got a very simple TNO, but it works really well. So AI will be an important part of the future of brachytherapy treatment planning. And those simple algorithms that, like the aforementioned cervix example, they work well for applicators with much greater density than the surrounding tissue. But AI can be useful for applicators such as these titanium needles. And they're shown in this prostate example. And these titanium needles are similar in density to other objects in the scan, like a gold seed or the urinary catheter or the bone. And those thresholding tricks, they just don't work as well. So here's some example of AI work that we've done at Mayo Clinic for interstitial brachytherapy. And I wanted to highlight one interesting thing we learned is that it can help to think like a human when you train your AI. And in this case, we reformatted our images sagittally. And we did that because that's how our physicists view the problem, as these long, thin objects. And we found that view helps the AI to better identify the long catheters, and it doesn't confuse them with artifacts like gold seeds. And it also does better when the needle starts to taper down and start to disappear. So the image in the middle is the manual segmentation. So I've highlighted kind of the inner lumen, plus I fattened it out a little bit to cover the needle. And then this was what the AI did, the AI segmentation. So it looks really good. If anything, it's a little bit smoother. And so the tool's kind of sparing you all of the details. What it does is it identifies voxels, the things which are applicators. And then we wrote a separate algorithm to cluster them into individual needles and then separate out any touching or crossing ones. And finally, we wrote everything into a treatment plan. Now, the automated digitization kind of accomplishments to date includes a vaginal cylinder that was done on CT, so that's been published, tandem and ovoids on CT, both interstitial and intercavitary GYN on CT, and then interstitial prostate on ultrasound, MRI, or CT. So that's kind of the extent of publications on automated digitization, but we're starting to see it grow into the different types of applicators, which is exciting. And if you read these papers, they each have a subtly different method. Like there's a kind of different approaches, and I think that's exciting too. So if you're interested in this topic, I think there's plenty to learn. Now that's all image-based, right? Like look at an image, find an applicator. There are some non-image-based tools that are very exciting, and I think they're just as good as the image-based ones. These are shape sensing tools that can be used to measure the location of a catheter without having to take an image. So the first one that I'm going to mention here uses specially coated optical fiber. So I'm going to show you a video. There's a YouTube link down there, and then I'll talk about it. But when you see this video, I mean, this is super cool. So this is a shape sensing fiber, and this person has this basically an optical fiber. They're moving it through space. They can bend it. They can kind of change the looping. So as this thing is perturbed, in real time, you get a sense of what its shape, and it gives you more than this. You actually can get things like you can get some temperature from these things. You can also get force. So like what is the kind of the resistance or bending that something's going through. So there are some really fun things that you can get from this. And so how does it work? Well, this is an optical fiber coating with a special grating, and only a certain wavelength then is reflected by the grating. So when the fiber bends, it strains. and that changes the spacing of the grating. And the wavelength of transmitted light then changes. And so they can read the transmitted light out, and then they know how it bent. And they coat these with a bunch of different gratings, so that you have multiple gratings on them. And that's their way to kind of break some of the degeneracy. And then the strain is used to reconstruct the 3D shape of the fiber. So they know how much everything is bent and in what direction it's bent. And that allows them to kind of basically walk through and reconstruct it. So I really like this. There hasn't been a lot of development. This is actually fairly new work. It's patented. It seems there are only like 2 companies in the world. I tried calling like at least both of them up, or I left, like nobody responded, right? I was like, hey, I'm interested in application. And you just get like radio silence. And so I'm not sure what they're doing, but it's really kind of hard to get a hold of these groups. Now, EM tracking is the other one. And this one, there are a few more producers of, and you can get some off-the-shelf products. And so this is going to use Faraday's law. So if I would take you way back to physics class, you change a magnetic field, produces a current through a sensor. And so the figure below is an example. So we got a field generator that produces. You're my 2-year-old again, I apologize, but she's doing her own work. The figure produces an example of a field generator. So this is going to produce a variable magnetic field, and that's going to lead to a unique signal in space. So this probe kind of reads out what the signal is, and then you know where it is in 3D space. And that's all managed with a control unit. Hey, Janie, Daddy's talking right now. Can you be quiet? Yeah, okay, great. So this actually is in use today. So the future is almost here. Example number 1. This is in Quebec, a clinical trial, Quebec City. They've coupled E&M tracking with an ultrasound system. So this is a custom treatment planning system from a producer, Euronav. And what they've done is basically try to do the whole workflow where the images, the probe, the template, all of those things, the stylet, they're all kind of in the same coordinate reference system. And as you push the stylet in, it knows where that is with respect to the images and the template. Really cool system. And I think they're getting some great results that we'll start to see soon. Number 2 is a little more R&D, but this is an HDR afterloader. I believe it's Electa that contains an EM tracking probe, and it's at the end of a dummy wire. And so they use that to automate the digitization of the brachycatheters using the afterloader itself. So afterloader wire, dummy wire drives out and essentially can tell the system. So you can use that as either digitization or QA. And so this is, they used in this publication as error detection. Like I got a plan and check it. And I'll talk about that a bit more in QA because there's another group that's been working on that. All right, that's digitization, which for physicists, that's like everything, right? But there's also the contouring, and these things can be rate limiting. So you may solve the digitization problem, but if you don't solve the contouring problem, then you're just waiting for the physician. Like physicist sits there and says, I'm done. And then the physician has to do their contouring. So how do we automate that part? Well, the work that's been done here is Shun Jia. That's kind of one of the leaders. And he's focused on gynecological at first, and he's got unpublished results for bladder, a snap oral that came out on rectum, and the sigmoid was published. And so there are advancements being kind of made here. It's just a little bit harder. We can't necessarily use the off-the-shelf products from EBRT because we have applicators that are really distorting that anatomy and they look different. So we need customized solutions for brachy. And here's how we can put it all together. So I want to give you a visual perspective. This is the auto brachy research platform that Dr. Jia has developed. And I'm going to play this video here. And it's going to show how the user is going to select an image set, kind of choose the prescription dose, and the automated system is going to segment the organs at risk. That kind of takes the longest. It's going to segment the applicators. It's going to place reference points and lines. It's going to set the applicator properties. It's going to set preliminary dose positions. And then it's going to also do a standard loading. They don't have the target contoured in this. And so they couldn't turn it into an auto planning system, but keep tuned in because that's probably next. So this is kind of crunching through. It gives you a sense that's real. Ooh, well, that was real time. It was like right at the end, and then I clicked. And then this is what it spits out. So you're going to get organs at risk, reference points, lines, kind of a very basic dose distribution. This is standard 15, 10, 10, 10, 10 loading, milligram radium equivalent. And you got it all. And it's ready to kind of head towards the next step. So the other change, so now let's kind of go look at the next principal component. So I said geometry's first. Second is dose calculations. And so the two major advancements that I think we can expect in future systems get us away from treating that patient as a big bucket of water. And so we'll see the use of AI for more rapid estimation of the impact of non-water tissues. And second, the incorporation of biological effects such as RBE. So there is some preliminary evidence from Dr. Enger's lab at McGill that you can train an AI model to mimic Monte Carlo, but do it much faster. And this was pretty clever. So what they did first is they basically trained the AI model to generate dose calculations in water. All right, so teach it how to do water. So it's doing TG43 without a formula. And then you train the AI to adapt the water-based calculation for patient heterogeneities. So it's like a differential, the difference between water and Monte Carlo. And then you train it how to do that part. And so there are three curves here, but you really can only see two. And that's because you've got the Monte Carlo in water is dashed. Oops, sorry, working my Mac mouse here. All right, dashed is the Monte Carlo in water. Dotted is the Monte Carlo in patient. And AI is the solid. And so the solid and the dotted are like right on top of each other. And then there's a little bit of difference in the dash. That's the impact of heterogeneities on this prostate treatment. And they were accurate with about 1 to 2%. And the Monte Carlo, while it takes minutes, the AI just took seconds. So it's basically free to get something that's pretty close to heterogeneity corrected. So this is a super exciting approach. The other change I think, or I hope we'll see, is how the dose is deposited in the nucleus. The microdosimetry studies in Dr. Enger's lab, they studied what happens to the DNA in the cell. And they looked at nucleus damage as a function of cell size and isotope. And it'll be helpful if future dose calculations can move towards a more accurate assessment of biological effect, handling BED instead of just dose. Okay, so if you're not too distracted by the background noise there and you're still with me, the next principal component of treatment planning is dose optimization. And so we've covered the geometry dose calculations, and the future of optimization, I think, has three features. The first is preparing for more complex optimizations that utilize rotating shields. The second is faster optimization for better plan selection tools. And the third is AI models that learn from past plans to generate a plan for your patient today. Okay, so those directionally modulated sources that I showed you in the prior slide, they make for great plans because they increase the number of degrees of freedom. But the downside of that, there's a cost, there always is a cost, is that the optimization problem is just much, much larger. And so we're going to need calculation tools that scale better with complexity. And I made this figure on the bottom. I said a cervix plan of 20 dwells, a breast of 60, a prostate of 150. And so I made this plot down here. And I did that to point out how optimization time on the vertical axis changes the number of dwells in the plan. And this was a variant treatment planning system. So it's a real commercial system. And so what's it going to do when it hits 500? So 150 dwells, it took like 1,000 seconds to really work its way through if you don't stop it early. And so 500 dwells, this doesn't scale well. It's a log scale here. But the good news is I think there's a solution. So the use of GPU systems is one way we might handle that problem. And this was exciting work by Dr. Bellieu's team, where they made 1,000 plans for prostate in 10 seconds. And they can do that by farming out the calculation to many, many GPU processing units instead of a single CPU. AI, I think, is a possible solution too, and I think it handles the problem a little differently, and I'll try to convince you that it actually might be a better way than traditional optimization. So it can be generated to produce past dwell time and dose distributions. That's bad news if your plans are horrible, right? Like then you're just reproducing horrible. But it's really good news if you have high quality plans. And the main advantages, I think, will be more consistent planning among our dosimetrists. And also, you're going to have two patients with the same geometry. And I think you're going to start to incorporate some of their qualitative aspects, such as where and how large hotspots should be. And that's often one of the hardest things. I get this interstitial case. It's not looking the way the physician wants because the hotspots aren't in the right place. And so the mathematical optimization does what it does, but it's not qualitatively producing the plans that we're looking for. And it might be a failure because we're optimizing to dose or how we've done our structures, but it sure would be nice to have an AI technique which looks at qualitative aspects and makes things look like they've looked in the past. I'm disappointed that I can't show you anything for brachy, but I wanted to hint, this is going on in EDRT with fluences. And so, it's an example of where they're creating fluences based on the geometry of the targets, the relative geometry of targets and organs at risk. We've got the same problem. We have the applicators are added to, so maybe a little more complex, but I hope to see that. All right, the fourth essential part of brachytherapy treatment planning was future is decision-making. And future decision-making will provide, I think, a better awareness of alternatives. It'll be AI that tells us what we should be able to achieve. And ultimately, number three is a stretch, but to present our plans in terms of outcome risk. That all this other nonsense, DDHs, like BEDs, like I don't really care about that. Like if I'm a patient, I want to know like what's my chance of like a urinary complication or rectal complication? What's my chance of having a recurrence? That's what's really meaningful, the quality of life indices. And so can we present our results in terms of those things that matter to the patient? And I hope so. So multi-criteria optimization. There's some heavyweights on this talk, so I should be very careful what I say. But how can you graphically present alternatives? And I think that's what makes MCO very, very useful, is that with much, much less time, you can tell people what's possible. And so this is a paper from Mayo Clinic where we weren't focusing so much on the algorithms of MCO, but we were focusing on visualizing trade-offs, so the physician can quickly appreciate the cost of improving one or more metrics. So let me show you one figure from the paper and just kind of talk through it. So focus on A here in that upper corner. The vertical axis is the percent change for structures. These are organs at risk: the bladder, the urethra, the PTV hotspot, and the rectum. And the horizontal axis is the coverage, the percent change in PTV D95. So very quickly, by looking at this picture, I know that if I change the D95, by 10%, this is the cost to those structures. The slopes are informing me the consequences of making something better or worse. And so I think this is a really nice way that the physician knows what they're leaving on the table or not. They kind of know what the costs were to these structures without having to re-optimize plans manually. 1 second. Janie, do you want to go in your room and play in the teepee? No. Okay, all right. Sometimes you can't win. All right. E in the bottom corner here, we have another opportunity. So when the slopes are flat, this time I plotted what happens if I want to lower an organ at risk. Well, the other structures are going to get worse. And so I've got PTVD, everything gets colder, right? Except some things get a little hotter. So the organs at risk, other ones might get hot, PTV gets colder. But notice that for the first 5%, hey, no cost, it's like free. So you kind of see something similar up here with the hotspot. And this is fantastic because now in very kind of a quick fashion, I can tell the physician, look, I think we should just like pull this rectum dose down. You're not going to pay much of a price to target coverage. And then right when I start to hit the inflection point, I stop. And so I just navigate to those regions, and that's pretty quick to do. So if you want to learn more of this paper, this was a really fun bit of research, and I do think it's useful, although I haven't really seen it integrated. Okay, Gene, I'll get you some water in just a little bit. The next bit is automated decision support. And so can we use AI to predict DVHs using the target and organ at risk contours? And this was a fun paper where this is exactly what they were doing. So here's their figure. The vertical axis is going to be the actual bladder dose, and the horizontal is the predicted. So they were able to basically just look at the relative positions of applicator, the contours, the target, and they could make a prediction about what they expected the dose to be. And so they still had some spread, and they thought that most of this spread was because the physicians practiced differently in their center, which I think we would all agree is true. But it hints at how we might be able to have some decision support that tells us whether our plan is consistent with past practice. And that way we can be confident in what we're delivering. All right, so I do hope that decision-making eventually converges on this notion of measuring and presenting outcomes risk, but we're still a really long way out from that reality. All right, chapter 3. All right, so stretch a little bit because we made it through chapters 1 and 2. We're ready for chapter 3, and I think I'm still on time here. I've got I'm about 15 minutes left here of the talk part, so I think we're gonna be right on time. And let me pause 1 second. I'm gonna tell my daughter, your canteen, I think, is over there, Jane, or it might be in the pink room.
I'm the polka dot one.
Okay, go find the polka dot one.
Your daughter sounds adorable.
Okay, I have to open a door here. One moment. Give me a second.
Yeah,
I'm like the
no
worst
problem.
speaker ever.
It's downstairs.
Okay,
It's downstairs. I don't know.
go get it, Jane.
It's in the door
All right, my wife got called in. She's a dermatologist, and so we're doing what we do. All right. So
No
chapter
worries.
3, automation of quality assurance. So we have plan checks. We have plan check software here, digitization and hookup verification, channel length, applicator commissioning, and source exchange. All right. So first, these are 4 papers that demonstrate advancements in automated plan checking for HDR. And they all do it a little bit differently, but there were some commonalities. And so these were the common plan check features. There were applicator lengths. There were dwell positions. So it kind of checked, is this a tandem and ovoid? And what should be the standard lengths for a tandem and ovoid? The next is the dwell position. So what is an expectation for what dwell position should be loaded? Or should there be any that are outside, for instance, the target, and maybe warn people if there's a dwell that's very far outside the target? Is the source model, the activity, are they in agreement with expectation? The dose second check, so it can automate that calculation second check, a nomogram, to check the patient orientation, the prescription dose values, so are they consistent with past practice? And this one's kind of neat. They presented the tip localization, so they made these little profile curves. By dragging a profile through the applicator, they show you the CT number as a function of distance so that you manually can kind of look at it and say, yeah, that looks right. That looks like the edge of an applicator or the inner lumen. And so these are things that speed up the process. We've done some things with scripting, and we've chosen some of these, not all of them, but it's kind of nice. I think the biggest catches for us, we've noticed things like we have detected the wrong applicator length where someone changed, they set the applicator properties, they thought they hit enter and they didn't. We have other ones where it warns us that you've got some dwell times that are a little too long or a little too short. And then we were able to kind of just speed up our nomogram calculations. So I like this tool. You can live without it, but it does help. What I really would like is this. I'd like to have some verification of digitization and hookup that isn't manual. And so the automation has been applied. This is like EM tracking is what's been used. And I'm going to highlight this paper from Burt et al., where they use a tracking system with fiducials. And so what they did is they basically ran their tracker through all the applicators, and then they registered that. They kind of minimized the registration with the treatment plan. And then they're going to look for an outlier. So I guess if everything was all moved superior or inferior, they couldn't detect that. But you can see if one catheter moved with respect to the others, or if something was swapped or shifted. So the kind of statistics on the right, they did really well with I would say, quite small shifts. And they did really well with swaps or if you accidentally digitized it in the wrong direction. So that's really neat work. And channel lengths were already kind of in clinical use here, that it can measure the length of your channel. And it's got an afterloader here. There's a Bravos afterloader. It drives out, kind of senses the inside of a lumen and reports the length of the channel to help intercept. And it'd be exciting to see whether we also see a decrease then in the medical event reporting for length errors. Okay, source exchange and daily QA. Just a couple more things here in QA. So during these quality assurance tests, the clinical user might want to evaluate the air chroma strength, the dwell position accuracy, the timer accuracy, the motor drive performance. And they've got this neat little radioluminescence tool that they use to measure those parameters. And they had some image analysis to automate the reporting of all of those metrics. So this is kind of hints at what a vendor might be able to sell you in the future that makes it just a lot easier to do source exchange. So it's going to upfront some of the work. You're going to have to commission these devices, and that's going to be a kind of a heavy lift to figure out how do I make sure this thing's doing it right. But then after that, the repetition of these processes will hopefully be more streamlined. If you've got an old Linac imaging panel available, this paper shows how you could automate the evaluation of programmed versus actual positions for new applicators. They use some MATLAB software for analysis and kind of able to find the centroid of these dwells and compare them against where they expected them to be. And last year, LDR, there's a team that worked on a method for seed tracking. They had a transrectal pinhole camera, and as a gamma camera, what they were trying to do is automate the seed localization, and their pie in the sky goal is, can we get real-time dosimetry for LDR prostate? Like, can you put a seed in, see where it went and start to accumulate the dose or give feedback about how far off the actual dose will be from the expected dose? And I'd say it has a little ways to go. So you can see that there's work to be done on perfecting sensitivity and specificity, but it is promising. All right. So we've discussed the advancements in the areas of applicator placement and treatment planning and quality assurance. And now let's take a look at what brachy might be 10 years from now. So let's put it all together. And more specifically, I guess I want to frame it in terms of how this will better meet the needs of our patients. So that all that stuff's great, but let's just distill it down to, the needs of the patients come first. And so first, brachy will be faster, and that'll mean less anesthesia, less discomfort for our patients. That's fantastic. The second is that brachy will be safer. So in the hierarchy of safety strategies here, the automation is one of the most effective ways to improve safety. And that's, these reminders, these checklists, they're all nice, but if you really want to make things better, use forcing functions and automation. And so if you remember that tightrope walking analogy, that picture, we're adding some harnesses and safety nets for our practitioners, and that's the most effective strategy. I think third, brachy will be more effective, that we don't have to look outside our own field very far to see that a robot or improved modulation or automation can improve quality of our treatments. So this is a plot of published data where I looked at the mean V100 for prostate brachytherapy, and look what happened when we went from LDR to HDR in these publications. So you not only see that the mean goes up a little bit, but the big thing, the sneaky one, is the variance, right? So you might look at it and go, oh yeah, I got a little bit better. But the variance was huge. And so that's what I think we'll hopefully see, is that we're not really measuring the variance of our brachy practice in terms of how good people are. We only know if they really screw up and report a medical event, or I shouldn't say it that way, if something terrible happens, because oftentimes these things, you're distracted. It's just, you thought you hit enter, you didn't, and it didn't take the properties properly. But what if we have tools that make it harder for mistakes to happen? Will we see better outcomes because what we're doing is reducing the variance? I sure hope so. But this slide is a take on the message from Dr. Adam Kuna during the World Congress of Brachy in 2020. And the future only exists when we have governments and vendors that are motivated to fund new research, which attracts top researchers who make technological advancements, which clinics can adopt, and that creates a cycle of innovation. And so whether you're a vendor or a researcher or a clinic, you have a vital role in that process. And this really highlighted, Adam basically drove this message home, and he said, like, we need to adopt technology. That if these vendors make things they cannot sell, then nothing's going to change. And so I guess we have a responsibility to the brachy community to not just be innovators, but also to try to be early adopters, even though it is work. Because if we don't adopt it, the vendors are going to stop funding R&D, and I think research will go elsewhere. I don't think he meant it as like a threat. I think it was just a really insightful statement about the importance, like, it's like so much work to like, I'll just wait till all the bugs are worked out. But somebody's got to work those bugs out so they can have some market share. And my last message will be on integration. And I think this is like the unsung hero of everything. And I think the integration of the automation advancements will be critical to the success of these technologies. It's like obvious, right? But like, you maybe didn't really focus on this part, but the conveyor belt is like maybe the most important part of this process, not the automation in each of these buckets. And so, the blue sky vision, we need to connect these disparate elements for a seamless experience. And so I'm going to give you an analog of cone beam CT. So this takes me back to like my first days in the clinic. We had early cone beam that provided imaging. It was like, this is amazing. And we had breath hold gating. That's like amazing too. But it had awful integration. And it took us like an hour and a half to do a breath hold liver SBRT in 2008. And now it's like 15 minutes in a decade. So nothing changed really in the fundamental technology, but the integration made it clinically useful and good. And so we don't have to look far outside our field to see what happens to technology that has poor or good integration. Design matters. I mean, it doesn't matter if it's architecture or art, or physics. Design matters. And so here are two top of the line phone offerings in 2007. We got the BlackBerry on the left here and the iPhone on the right. And so here's what happened to those companies over the next few years. Here's BlackBerry and here's the iPhone. And so, Apple invested a lot in user experience, and I think it shows. So there's an article too. There's an article for everything. Lisanne Bainbridge wrote this one in 1983. So like way back. This is before what I call the age of automation in 1995, right? So, and her paper warned about a paradox of automation, that the role of humans becomes more important if we adopt automation strategies, and that it makes it even more critical that we focus on integration and user experience. So she said, the more efficient the automated system, the more crucial the human contributions of the operators. So that's like a warm fuzzy, right? Like I showed you a bunch of automation. No one's losing a job here. It's just becoming more critical that you know how to do your job well. So in summary, brachy is in an era of automation. The automation is rapidly being developed and tested. The recent and ongoing advancements will change how brachy is performed during the next decade. And I think the success of automation hinges upon robust integration of these technologies. Thanks for your time.
Well, thank you very much. Fantastic talk, especially for those of us that do a lot of brachy. This is really intriguing. Do we have questions in the chat from anyone?
I have Sam questions if I'm supposed to present them, or maybe everyone's just supposed to do them at the end.
Jen, do you remember?
We'll send out the Sam questions at the end.
Okay. All right.
I do have one question, Chris. So, what you mentioned at the end there about integration and that you gave the smartphone example and the external beam example, but do you think that brachytherapy as a business, as an industry, is it large enough? Is it a large enough sector to be able to see that kind of investment on the commercial side to make that a reality?
This is such a great question. What I think might happen is it's going to be a tag along. That is to say that I think a lot of advancements, like the tools will get kind of worked out, and one by one, some researchers like us will say, hey, I can apply this sort of tool. And I do think we'll see it adopted, but it's going to be a laggard. I think so. It's not going to be leading. Now, I did chat with a vendor. I won't say who the vendor is. And they don't do a lot of brachy. And I gave, I basically presented, I said, here's interventional radiotherapy. Here's why it's wonderful. And here's why it's like, I can warn you, like the market share is low because it's time consuming. And they go, and I showed them the workflow. And then I walked through basically this sort of automation pitch and said, here's how we can redesign the workflow to make this thing fast, like an hour in and out. And what they kind of, their eyes popped out and they're like, this, what you said in the beginning is just an opportunity. Like the reason people don't do it is because it takes time. And like, raise your hand if you've seen a physician basically stop doing brachytherapy because they're like, I don't have time for this. Like, I don't have 4 hours to do an HDR prostate. Like, I'm just going to do beam. But if we can make it a better experience for everybody, I think it's almost like a chicken egg problem, right? Like if brachy is an hour, then like everybody's doing it maybe because it actually reimburses really well. There was a great talk, was it the too many conferences? Okay, so what this talk basically looked at is it said, how much time does it take and what's the RVU per minute? And what is the cost for personnel? And it was like 60% of brachy was personnel. It wasn't equipment, it was all people. And so if we can shrink the time it takes, then you have less anesthesia, you got less, physician time, less physics time. So I'm not answering your question directly. Like, I guess basically I'm saying, I don't know how to get over that hump, but I think once we get over it, and it might be that we're just a bit of a laggard. So like we can hang on to brachy for a while here. I think we'll get to a point where it won't be so difficult to do and it'll be better. And then suddenly, it won't be a threat anymore because it'll be cost effective and maybe we'll see growth.
Yeah, I know this is a bit of a tangent, but possibly with the episodic payment models that are going to be hitting many of us soon, that may change some thinking along these lines where, the technology or fractionation won't really matter as far as reimbursement. And brachytherapy, of course, is exempted early on, so it's protected in that sense. But over time, we may see the incentives change a little bit. And
it can't be a coincidence, right, that Canada and Europe do a lot of brachy. Like they do a ton of brachy. And I got to think that if our healthcare system, I was just looking at that number of like twice as many cancer patients and thinking Medicare is going to explode. And so when they do systematically start to, cut reimbursement rates, and if external beam brachy won't get much of a haircut, but if EBRT gets a 50% haircut, that changes the economics of brachy a lot in our favor.
Yeah. And to your point about physicians and time, Dr. Sue, who spoke earlier, who I work closely with and does a lot of prostate brachytherapy as well, has pointed out exactly that to us. That he's a big believer in it, but he said, I need to be able to do multiple prostate HDRs in the same day. It's too sequential and too slow for us right now.
Yeah, I didn't say it outright, but the way I think this is going to happen is the combination of the tracking technology and the essentially image guided approaches. That I imagine what we'll be seeing is a patient gets a scan, the physician will have to draw a target or confirm a target probably, and then once they've done that, essentially in a matter of a minute or minutes, we're going to see a plan, because all the other stuff is going to be automated and we're going to have automated planning and so forth. And then the next part is, well, who has to check it or look it over? And I think it will be helpful to have the afterloader or robot that basically does a confirmation of the digitization. And now you've got decision making that's just kind of happening right then and there. And there's much, much less delay. That's what I think is going to happen. It all depends on integration though too. And that's where I think we're going to get hung up on, is that how much of it has to be checked by a human, and how easy is it to do that, and what tools do we have, and how does the data transfer? Does it transfer well, or is it clunky? But there's really, I think if we threw enough, like if we had EBRT money, like if we had the kind of millions that they had, I think we would see a solution where we would get patient treatments, including applicator placement, that are within an hour. Really good ones.
That would be a good future.
Yeah, it's going to take some time though. I think you're spot on. It's really, there is a threat to that future, right? It's at risk due to the pace at which we're changing is limited because of the economics of brachytherapy. Yeah.
Oh, thank you. Any other questions for Dr. Deufel? All right. Well, thank you again so much. That was really
Absolutely.
enlightening.
Always fun.